Hello, everyone, and welcome to today's webinar with the title Transformative Workflow Mastering Integrated Decision Making for Greater Confidence in PLT Clump Management. My name is Telmo Costa, and I will be your moderator today. First, thank you all for joining us, and we are very happy to have you here for this important session. Today's educational webinar is presented by LabRoots and proudly sponsored by NOUL, our company. For more information about NOUL, please visit our website, noul.com. It's a pleasure also to introduce our speaker that will guide also part of this webinar, Dr. Renske van den Bigaert is a very difficult name, but please, I kindly ask you to introduce yourself.
Yes, thanks, Telmo. My name is indeed Renske van den Bigaert. Let me correct you a little bit there, but it's very difficult, I understand. I'm a clinical chemist in training at Clinical Diagnostics Gelre in the Netherlands, and I will be telling a little bit about the laboratory process of platelet counting and also share some first results on testing with the NOUL machine.
Thank you, perfect. So let's move forward. Just a quick look about our agenda for today. So I will give you a short overview about NOUL company, and also then I will hand over to Dr. Renske to start giving a perspective about in the laboratory regarding the PLT counts and the challenges. Afterwards, I will present the MyLab BCM features that can add value in this type of workflow management. Finally, we will have an interactive session where we'll wrap up all the key message and the key topics that we were discussing today. And also we will have a time for the Q&A for the audience to address any kind of questions and explanations that are needed. So I will start. So the NOUL is a South Korean company that was founded in the more or less 10 years ago, 11 years ago, so December 2015, and is already with more than 110 employees, associates, and we are already going across the globe with several activities. So the company was starting regarding all the processes and also all the regulations and also partnerships with key stakeholders to help us to develop the product, to place the product in the market. As you can see here, so this is the road to the global success, where you see different non-governmental organizations like the Gates Foundation and WHO, and as well also other partners like UNITAD and also Neon Coden that are working with us for place the device in the correct segment and as well in the different markets. What is MyLab? MyLab is a hardware, a system that will, a platform, let's say it, that will be able to perform 3 different type of tests or processes. Like say like this. So one of the applications is the MyLab Malaria. So it's the first application that was developed, and this will provide a diagnostic of malaria, positive, negative, as well can do the identification of the species and also the level of parasitemia. Then we have the BCM, blood count and morphology, our product that we will talk about today, where with a single cartridge base with a very low amount of sample, 5 microliters unique, we can deliver a CBC 5-part differential counts and as well complete morphological analysis supported by AI. Everything based in the microscope technology. Then we have the other product that is the MyLab Cervical. Sir, it's for screening of cervical cancer, and this is also based in the same type of technology, cartridge based and microscopy based, that will support this screening. So we have more than 100 organizations across 25 countries that are our partners, and they are conducting research operations in several places in the world. So this is where NOUL is already playing in the IVD market. So after this short presentation of an overview about our company, I would like to hand over to Dr. Renske, that will start with the first part of our session, how to show the perspective of the laboratory itself on counting platelets. Please.
Thank you, Telmo. So it all starts with an indication why platelet count is needed, and a clinician or a general practitioner can ask for a platelet count. And there are several indications. For instance, it's part of a complete blood count. If a patient experiences bleeding symptoms, platelets count can be very useful. Also in monitoring diseases that affect platelet production or destruction, or during the monitoring of medication to see how platelet count is affected by that. And when the clinician placed an order, the patient will go to the hospital, get his or her blood drawn, and that blood is then transported to the laboratory, where technicians work together with the machines that are there to count the platelets or evaluate any other parameters that are placed in the order. And specifically for counting platelets, there are different types and methods present in the laboratory. One of them is the impedance method, where there is an electrical current that's placed over a very tiny hole, and then a single cell suspension is pushed through that electrical current. And every time a cell passes, this current is interrupted, and that generates a pulse. And the machine counts the amount of pulses to see how many platelets are present. And also the size of the cell that is pushed through this electrical current can be measured, because that is visualized in the height of the pulse. So you can imagine if a platelet passes through, a small pulse is generated. But when there is a clump of platelets going through, that the signal can be higher. And then the machine cannot know if it's a big cell or a clump of platelets. And as a follow-up, we can also do flow cytometry staining, where a fluorescent dye is used to stain the platelets. And this is another method that the fluorescence can be detected, and the amount of platelets can be determined. And the results can be reported, and the amount of platelets can be normal, and there is no action needed. The amount of platelets can be high, for instance, during an infection in the presence of a myeloproliferative disease. And the platelet count can also be low, for instance, in cases of blood loss, increased use of destruction of platelets. There can be a decreased production, but there can also be pre-analytical factors that play a role, and that cause the so-called pseudo-thrombocytopenia. And that is the presence of aggregates in the blood sample. And the machine gives you a low count, but there are actually enough platelets. It just cannot count it because they're clumped together. And it's very important to know if there is a real thrombocytopenia or a pseudo-thrombocytopenia. And to assess this, we prepare a blood smear and we perform a manual review under the microscope to see if platelet aggregates are present. So two of the possible results. Here you can see a blood smear where you can see red blood cells, but there's hardly any platelet detected. So in this case, the patient has a real low platelet count. For the next patients, you can see that platelet aggregates are present. So the platelet count can be low, but we know that there are more platelets because they are there and just clumped together. And as I said before, it's very important to determine the cause of the low platelets because it has a clinical relevance. For low platelets, it might raise patient concerns. Also, there's a appropriate follow-up or treatment needed. For instance, citrate can be used to mitigate the pseudo-thrombocytopenia, and it also avoids unnecessary follow-up diagnostics. So reliable platelet quantification methods are very helpful when aggregates are present. And to address this point, the NOUL visual counting can be helpful because it visualizes the platelet clumps and can also count the platelets that are present inside these clumps. And Thelma will tell you a little bit more about the machine and the technique behind it. Thelma, you're still muted.
Thank you very much. Sorry, I was muted for this introduction to put everybody aware what are the challenges in the laboratory and what are the technologies used to count PLTs, in this case, platelets. I will give an overview how and what features the MyLab that was tested already by Dr. Renske could close some gaps in the laboratory and could increase efficiency, workflow in all the processes. So as you know, when you have to test the blood, so there's an order that the physician will ask, then the drawing of the blood goes to the laboratory performs the test, in this case it's a CBC, and if the CBC, the instrument that is in the laboratory, delivers a flag, needs to go in the second step, in this case to the morphology or the smear revision, and have a confirmation of this flag. So then all these steps are pretty much manual steps, to preparing the smear, making the staining, and as well to reviewing under the microscope. And so at the end of all these steps, the patient will receive the diagnostic. Usually, the patient in ambulatory situation don't receive the results in the same day or at the same time of the appointment. Usually the patient needs to go 2 times to the doctor, one to draw the blood and another one to receive the results. So this is quite annoying for the patient as well, and because it's disturbed the normal routine life. So what could MyLab address and improve the situation? So all the manual work regarding the preparing the smear, preparing the staining, and also make the first analysis can be automatized by the MyLab BCM. So the system will be able to perform with 5 microliters of blood the smear, fixation of the smear, and also the staining using the right GIMSA staining, a Romanovsky modified technique that is common in a laboratory, then present for everybody, that everybody used to. So the smear that is produced by the MyLab and the staining, the quality of the staining is equivalent of all the normal stainings that are used in the laboratory, in this case, the right GIMSA staining. So The MyLab ECM is the blood count and morphology, is a 5-part differential analyzer with morphology analysis by microscopy supported by AI. So the AI and artificial intelligence is embedded in the device, is not in the cloud or online. So even if the device is not connected online, continues to work with the same algorithms and the same intelligence that is in the back of our system. This is for safety reasons, because we need to control the algorithms and also the knowledge of our AI in a way that doesn't create any type of false negatives or false positives that could lead in a severe situation for the patient. So, key features from our device. We have intelligent automated workflow. What this means? It means that we have a cartridge system where the user places 5 microliters of blood and then introduce the cartridge inside of the analyzer. Inside of the analyzer, the process is completely automatic. So the system will perform the smear and then will identify where is the monolayer of the cells, and in that area will make the staining using a solid staining that is the core of our product, where there is no liquids and there is no waste, liquid waste, because all the stainings are done using the hydrogel technique, where the new methylene blue, also the ozine, and the buffer is in a solid state. Afterwards, the AI will perform the analysis of delivering all the countings that we are that are common in the CBC 5-part differential analyzer, and also will make the morphology analysis of the 3 series: the white blood cells, red blood cells, and platelets, generating flags. And these flags, it will be associated as cells that are abnormal identified. This is possible for the user to review and also to reclassify using the software viewer that will allow to see in the bigger screen, and also with more easy way to share and to discuss the results with other colleagues. So what happened? The idea is that we will be able to eliminate manual steps, decreasing time, turnaround time, and as well standardize all the methods. So with the MyLab BCM, it will be possible to have all in one a slide maker stainer and a microscope integrated in the system, with the capacity to deliver a CBC 5-part differential and a morphology analysis. So the other part of the solution that is provided by NOUL is the software itself. So in the results display in the device, you see the background is black. Is small because the device is quite small and could be difficult to see the cells in a perfect way. So the best is the user of the viewer. The viewer is a software that the NOUL make available in any situation of the laboratory, in any workstation that is necessary to be installed, that will support the analysis, the review of the results, and reclassification if it's needed, the generation of reports, and as well creating new subclasses of cells and making a different classification of the abnormalities that are present. Based on this technology and this solution, NOUL team and also myself see that the hematology, it will follow a decentralization where the in vitro diagnostic technique, it will be close to the patient. This will decrease costs, this will improve the patient outcome, and also the patient experience. So our device, it's designed to work in satellite laboratories with GP clinics, with emergency rooms and intensive cares, also with pediatrics because of the low volume of sample. So the system is not to replace any hematology analyzer that is already installed in the big laboratories, but to work together and close the gaps, improving efficiency in the workflow. So after this short presentation of the key features of the MyLab BCM, I will hand over again to Dr. Reska to present the other side of their work and what they found during this time that they were testing the MyLab BCM. Please.
Yes, thank you, Telmo. So I wanted to start off telling you a little bit more about the laboratory here. I'm part of Clinical Diagnostics Gelre, and we are based in the Gelre hospitals in Apeldoorn and Zutphen in the Netherlands. So we have a main lab in Apeldoorn that serves or does all the diagnostics for the clinicians in the hospital, but also for the general practitioners that are in the surrounding area. And then we also have a satellite lab in Zutphen, in a smaller hospital located over there. And we serve around, or we do the diagnostics for around 2,000 patients per day. And we started off using the NOUL, I think about a year ago, for a pilot study where we compared flow cytometry system of Sysmex that we currently have in the lab with the NOUL MyLab BCM method, and also we use manual counting as a alternative of platelet counting. So we started off by doing a small pilot study where we included several patients, including healthy donors, patients with lymphoproliferative diseases, patients with reactive lymphocytes, and diverse other patient groups. And we did a general assessment of the NOUL and compared it to the Sysmex hemocytometer. And there we saw that the NOUL and the Sysmex compared very well in terms of platelet count. But one sample attracted our attention, and that one is in the upper left corner because it had a low platelet count with the Sysmex. We received a flag that platelet clumps might be present, but we got a pretty high count with the NOUL BCM MyLab method. And this was a patient in which the pseudothrombocytopenia was observed. And this triggered us to do a follow-up study to look at patient samples with specifically low platelets or where the Sysmex gave us flag for platelet clumps. And on the left-hand side, we included 98 patient samples and measured it on the regular routine Sysmex method and also on the NOUL method. And you can see that overall, they measure quite similarly, but there are a few samples in which the NOUL measures a higher platelet count than the Sysmex does. And when we compare the NOUL to the manual method, we see that the person who counted the platelets is usually counting a little bit higher compared to the NOUL. It really depends on where you are counting in the slide, how many clumps are present, how many fields you're counting. So there's a little bit of a difference here. And what is helpful is that NOUL detects and reports also the amount of platelets that are observed in the slide. And we split the data based on a a few platelet clumps, so below 15 clumps that are observed by the NOUL MyLab, or more than 15 clumps that are present. And what you can see is that when there are fewer platelet clumps present, the NOUL and the Sysmex count a very comparable number of platelets in each sample. So there's a good correlation there. When there are quite some platelet clumps present, you can see that the NOUL usually or regularly measures higher than the Sysmex does. So here it can have an advantage to have a more accurate count with the NOUL. And I have to say that it's an initial study, so we're still adding more samples to this data set. And also to have a look ahead, we observe different types of platelet aggregates, sometimes as we define them normal, or it's very easy to count the platelets inside the clumps. Sometimes the platelet clumps are a little bit transparent or vague, and it's pretty hard to count the clumps in there. And also they're closely packed clumps. So we want to see in this data set how the NOUL treats or handles these different types of clumps when it's counting. As said, we want to increase the sample size, and that's why we are also starting a multi-center study, also to include different routine settings and laboratories. And some of the labs that already have confirmed to participate are Oxford University Hospital, St. Thomas Hospital, BCRT Berlin, and Diagnosticum Plauen. And what we would like to include as well as a fourth method is to have a flow cytometric antibody staining panel as a comparator to really quantify the platelets inside the patient samples. And with that, I think we're going to start our interactive session. Telmo, you are again muted.
Thank you very much. And first of all, I think this is a really incredible work. NOUL and the NOUL team really appreciate your work and the scientific way that this topic was handled. And hopefully with this multi-center, we will achieve a more solid conclusions that will guide us placing the MyLab PCM as an alternative method of PLT counting in the presence of clumps. So this could be the final, and it's what I see it as achievable. But picking up now all this information that we talk about it, I would like to ask you some questions. So in your opinion, in thinking about your daily routine in the laboratory, what really makes the PLT clumps difficult? What is the big borders or hurdles that you face in this situation?
Yes, well, we need to know for sure when we are reporting the amount of platelets that we report a reliable result. So we need to know if it is a real thrombocytopenia or if it's because of platelet clumps and the actual platelet number is higher than what we receive as a result initially. And also it creates some extra steps. So we need to make the smear. The smear needs to be manually checked for platelet clumps. So it's a multifactorial challenge that we face while we are counting platelets, let's say.
Yeah, and this can disturb a lot the normal workflow, correct?
Yeah, it takes extra time to review the slides. It's you can never predict when a slide is coming, so it can be a very busy time. Yeah.
Okay, so where the normal systems, the normal analyzers that are installed in the laboratory break down in confidence regarding the PLT countings, where do you feel that they get struggle with this situation?
Yeah, so the analyzer flags for the presence of clumps because it sees or it thinks it sees clumps or the amount is low. So there's already an uncertainty there. And also the smear is made and you need to manually check it. So it's also, for daily practice, different people or technicians in the lab are looking at the slides. So there's someone can maybe look at another area than another person would do and come across a platelet clump. So
That's
it's hard
the
to
miss of
standardize.
standardization. Yeah, that's it. Sorry.
Yeah, exactly.
Okay, so the standardization is one of the hurdles present in this PLT clump management workflow. What did the conventional pathway looks like? So in a normal situation, like you described in the beginning, the patient comes, takes the blood, and then the analyzer makes the analysis and so on and so on. Then we have a flag, and then we have all the situation that it comes. What is the really the break or the time consuming in this pathway regarding your experience?
The checking the slide manually takes most of the time, especially when the platelet aggregates are not popping up, because you want to really make sure that you did not see them or you are not missing them. So you're checking the complete slide. And as I said before, different technicians can look at different areas. And I think every lab tries to standardize this as much as they can, but there's still different people involved. So we everyone tries to do their best, but it can be different. And also judging if a platelet clump is one clump with just two platelets together, it might be considered as a clump.
Or not?
Or not, yeah. So it's hard to standardize these kind of things.
That's
You
true.
can make, yeah.
Just a question. Just a question could be beneficial for our audience. Do your laboratory estimate PLT counts and report estimation of PLT counts?
You mean estimation by manual counting?
By the manual microscope, yes. When you have the clumps, so this number is not reported or is reported?
No, we do not count manually and give that number. What we do in the lab is, so the Sysmex analyzer gives a count, but it reports a flag. And then we start looking at the smear. And if there are aggregates present, we say, this is the amount we measured, for instance, 25, but we see aggregates. So we know the number of platelets is actually higher than 25. That's what we report. We don't do the manual counting and give an estimation of what we think is in the slide.
I can imagine with this situation, lots of medical procedures like surgeries and so on could be canceled or postponed because of the PLT count is not available. True or not? Maybe, yes.
I have not heard back anything regarding that from the clinic. So it's hard for me to comment on that.
I hear in one of our participants in the multi-center study, that's what they comment. So they don't report as well the PLT count when the clumps are present, and this it's a really, really big problem because of the cancellation and reschedule of some of the procedures that the clinicians need to do. So when you start using the MyLab and we identify that the system is looking to the smear like we do with our eyes. So we see a clump and we can see the platelets are are for forming that clump. And so the system is able to count the PLTs that are in the clumps. So what do you feel different now when the MyLab comes to place? Let's put it this way.
Yes, I think it gives a more structured and standardized process. Yeah, so when we count using the MyLab, it gives us a number, and what we feel like is that when there are more clumps present, the number is higher and reflects more what we see. So I think the counting and the morphology come together more, which makes sense, and that yeah, it helps in the confidence that you can give a more accurate count in the presence of platelet clumps. I think it's still early to conclude that, but the first results look very promising.
So you already described this. What are the practical signs that you were seeing? So that the countings that the MyLab ECM is delivering in the presence of the PLT clumps are always higher than the countings from the traditional hematology analyzer. So at least we need now to prove and increase the database that the counting is really the number that the patient is with. And of course, it's a big step forward when we have a better and more accurate PLT count in the presence of clumps. So I think, please, Dr. Eske, if you want to add something in this topic.
No, I think the graphs that I showed previously shows that is certainly in some patients it's beneficial to have the NOUL is beneficial to have a more or the count reflects the amount of platelet clumps more than with the standard routine analysis.
So I just have a question, just to be clear. I know that you have the Sysmex analyzer in your laboratory, and you use also the PLTF channel, so that's the dedicated PLTF channel for PLT count. You see the same trend between the two channels?
That's an interesting question. I am not 100% sure if I have never looked one-to-one to see how it compares, but that might be interesting to look at to see how the
PLTF channel improve compared with the impedance. Yeah. Okay, so there is an approach add value in our solution as you can expect it. What do you think?
I think it's a repetition of already said earlier that the visualization of the smear and the counting, they are considered together. So I think that is very helpful and could be an added value in a lab, especially for patients that have clumps.
So what should the other labs evaluate first in this kind of scenario? So what is your advice regarding this new pathway that we are presenting here today?
I think it's important to look at the current process and see where, how the process is placed in the lab, and see if the NOUL can help in that process. If, for instance, there are problems with the reviewing of the smears, it can be helpful to have a machine there that does the counting for you in the presence of clumps.
Yeah. Okay. So just to close it, I think that one of the key messages that you just addressed is that not only the numbers are important, but also the integrated review it's the best approach in this kind of situation. So where the numbers and also the images and the cells that the morphology analysis that are available integrated in one could support to achieve a more reliable counts from the PLTs when presence of clumps. So I think this will also increase confidence in operational way, because we standardize the methods, we decrease manual work, and this also will be reflected in the turnaround time from the laboratory, increasing efficiency. So what we can say is that the evidence that we are now having from your hard work, and that you did it a great job, you and your team, and it will be expand now to different regions of Europe. So we will go to England, we will go to Germany, probably we also go to France, and different type of settings, different type of ways of work, different type of analyzers itself. And that's what we want to include, this most variable as possible scenarios that we can prove effectively that the MyLab is can be considered as an alternative method in the laboratories for counting PLTs in the presence of clumps. I want to say again, thank you very much, Dr. Renske, for this work and to bring this topic here today. And I'm sure that we will continue working for the next month, I believe, at least, with this topic, and the conclusions and the goal, it will be achieved for the beneficiaries of everybody that is also listening our webinar.
Absolutely. Thank you for the invitation and the opportunity to share our initial findings here.
Okay, thank you. So now we will move to time to give to our audience, where you can address your questions and clarifications. So you cannot verbalize, you need to write your questions in the chat, and we will answer your questions live until the time allowed us. If the time is over and some questions are not answered, you don't be sad, because we will answer everything and send by email all the answers and follow-up questions itself. So also after this Q&A session, it will come a questionnaire to give evaluation about our webinar and how important it was, and what kind of improvements you see it for the future. So please don't forget to answer to our questionnaire. That is very important for us to receive your feedback about this session. So let's see if we have some questions already. I see it. So we have at least 3 questions that come. So first one says, so are these point of care devices or for main lab? So to clarify, the MyLab BCM is a device that is designed to decentralize the measurement of the full blood cell count, okay? So it means that the device is designed to be used in point of care settings. Nevertheless, in this situation, we see a benefit in the add value that the device go to the central lab to be used as the alternative method to count platelets in the presence of clumps. So it can be in the 2 sides of the setting, so core lab or point of care settings. Do you have data from the comparison of the other cells? I don't understand this question. Of course, I understand the question now. So the evaluation that Dr. Renske and her team performed, it was for the evaluation of the full system. So now, here we are only presenting PLT countings, because this was the one that called attention for a different type of study. Okay, so the other cells and the other parameters, of course, they were evaluated and they were correlated with the Sysmex analyzer. Correct, Dr. Renska?
Absolutely.
Okay, so sorry, I was taking the speed and answer everything. So,
No worries.
um, will the machine count the PLT count even if they are PLT clumps in the sample? So low PLT count or a high PLT count will be counting even if they are clumps? Yes. So what is happening here, apart what I understand this question. So if you have a PLT the count or patient with the normal count of platelets that is with antibodies against the DTA, it will generate a clump. So we will see a low count of platelets that will be a pseudothrombocytopenia. However, the MyLab, it will count the platelets that are in the clumps, and so the patient will reveal a PLT count normal. So this is what we are seeing. This is not written in stone yet, because we need to go further in our study and increase the database, but this is what we see. So this is what is happening. No matter if the PLTs are high or low, if they are clumps, the MyLab will deliver a more reliable PLT counting in that situation. That's what I can say. Dr. Renske, you want to add something?
No, I think that is indeed the point. And a low platelet count or a high platelet count in the presence of clumps, it just counts it. So if it's the platelet count is high, you will just get a high number. But we have focused mainly on the low platelet counts.
Yes,
but in
that's the
the
dangerous part.
initial study, we did have some patients with high platelets.
Yeah. So there is a question that also came up. Are there any interferences with the blastic cells of malignancy cells or parasites? So these interferences usually are described for the conventional hematology analyzers that use impedance, fluorescence, flow cytometry, and so on. So we are using microscope. We are seeing the cells like they are. So like our eyes are looking to the smear. So the interferences don't happen in this way. Okay, so the system will not interfere the countings regarding blastic cells and parasites, for example. So because the cells will be separated by like we were looking to the microscope manually to review a smear. Okay. Did we compare the PLT thread count with in MyLab PLT count, Dr. Riska? So there was CTRAT. Yes, please.
Yeah, we did have some patients where, in addition to EDTA blood, there was also a citrate blood taken. And we unfortunately not have enough patients yet. And we do see a diverse pattern that sometimes the citrate compares to the MyLab PLT count, but also sometimes that the citrate is a little bit lower than the MyLab count, and also vice versa. So it's hard to say, I would say, at this moment, but we're looking into that.
We cannot exclude as well that the citrate could also induce in some patients still aggregates. So it's not 100% secure to eliminate all the aggregates. So maybe the antibodies are not so strong, but still some could be there. Okay, another question. Here, a question is regarding the time of each evaluation. You know, the time is variable. So we don't want to do the things in a hurry. We want to do the things with time to collect the right amount of samples, to have the good database that is robust enough to then deliver good conclusions. So we don't think about the time of each evaluation. We are just moving up when the samples are available. So this is what will happen as well regarding the multi-center. Maybe some hospitals will be more fast, other laboratories will be more slow, depending of the availability of the sample. So it's difficult to judge this. So
Yeah.
a PLT clamp is a 3D. Sorry, please.
I think what
Please,
we could add is that for the whole process to be done, it takes about a minute or 20 with making the slide, staining it, making the pictures of all the cells, just to have an idea how long or short it takes for the machine to complete one cycle in the process.
Yeah. So we deliver around about in average between 15 and 20 minutes, depending of type of sample, because of the number of cells that is counting. And if you do it everything manually, this time it will double or triple, I'm sure. So because even for the mood that the technician is with to do the staining and the manual smear, that's happen quite often. There is a quite interesting question regarding the clumps are a 3D structure. So does the MyLab use the Z stacking to count PLT clumps in the clump? No, doesn't have that, because this is a smear. So this is the same process like we do a normal smear. So it will be only have 2 dimensions, okay? So it means that the 3D structure, it will be squeezed against the glass of the smear. It will be the same way like we see it. So you can think in maybe some PLTs will be under one PLT. That could happen. But what we see is that even with that situation, the countings are much more reliable than using a PLTF channel to count PLTs in presence of clumps. Okay. So we observed that for samples with PLT clumps higher than 12, the MyLab tend to report higher values than Sysmex. What do you, Dr. Renske, think could be contributing for this overestimation? I don't believe that is overestimation.
I was going to say, is it an overestimation or is the Sysmex having or doing an underestimation?
Of course.
That's hard to say. I think adding the flow cytometry data might be helpful in this case. But it's great to see that we see similar results.
Yes. Yeah. I believe because the number of clumps is too high, and of course we report higher than the Sysmex because the Sysmex gets more blind to the clumps. So because the Sysmex is blind to the clumps, if there's a lot of platelets that are in the clumps, of course the count is low. And we don't see this in the MyLab. So that's why I don't see overestimation, but a lower estimation from the other side.
Yeah, and I just want to add that yes, we do see this with Sysmex, but I think it's a general hemocytometer analysis.
Yes, independent of the technology from Beckman Coulter to Siemens, Crossing Abbott, and Oriba, all suffer from the same limitation. This is not a problem. This is a limitation of the technique, the technology. So that's all.
Yeah.
So, do you ever seen this type of platelets clumping only in recent samples? Oh, I don't understand why samples before 2020 and after 2020 is connected with the COVID vaccine, maybe? There is
I
a
have
question
no idea.
that
Our study was after 2020. I'm not sure if in-house studies were done before 2020.
Because I believe that this could be related with the vaccine and the COVID-19, because that's the 2020 border that is here, and to see what was the effect in the PLT clumping. I have no idea really about this. This is something that could be investigated in the second study that we can think about it. how many cells are counted as part of each test? Also, are there any issues of detection if PLT clumps are pushed towards to the edge of the blood film, as often happen in the PLT clumping? So, in this situation, the cells that are counting of each test dependent of the cells that are available, because the time is the stop counting of the system for the PLT counts. And the ones that are pushing to the edge, and because the system use the same type of counting like we did it in the former times with the new Bauer chamber. So we have a fixed volume in a chamber. So we count a significative area where the cells are placed, and then there's a calculation based in this kind of new Bauer volume that is addressed. This is the same principle like impedance, because you need to have a aperture with a fixed diameter, because this fixed diameter and the volume that you are measuring through the chamber, it's the one that will be used to calculate then the final result. So this is the same principle. The difference is that we don't use impedance, fluorescence, or flow cytometry. We use the microscope from all life like before. So our AI use the same principle like we did to count the cells in the smear. I hope that I was answering the question.
Yeah,
Oh,
and the
we don't have more questions, so I think we clean all of them. I think
just,
it was really,
sorry, can I comment on not the last
please.
Question, but the question before that, the 2020 before or after question? A clinical chemist just came into the room and he said, we see clumps for years. So it has nothing to do with COVID. It's just a general thing that happens in the population.
Okay, that's a good sign that we don't have another consequence of the COVID-19. So I would like to say thank you once more to Dr. Renske and all the team, also the technicians that work with her, the hard work that was performed, and the continuation of this hard work. And we try to support. Thank you for your presence here today. It was really, really beneficial for all of us. And I also want to say thank you to all the attendants to this webinar. And please answer to our questionnaire to give a feedback regarding our today educational lecture. And I want to tell you that this topic, it will come again probably with a second edition when the multi-center probably it will have more results. So stay tuned and you will have the sequel webinar for the PLT Clump's workflow management. Thank you very much and have a great afternoon, morning, or night, depends the place that you are listening to us. Dr. Reska, some words?
Thanks everyone for all the interesting questions. And yeah, as you said, have a great morning or night or day.
Yeah.
And